I'm going to be discussing the use of the OCT in the diagnosis of optic disc edema and pseudo-papilledema. This is in part a collaborative effort that was based on data that I was fortunate enough to have access to as a member of the OCT sub-study group and the Optic Disc Drusen Consortium. Everything I'm going to discuss in this lecture can be done on any commercial device. I'm not endorsing any particular device. The OCT has enhanced our ability to manage a variety of ophthalmic conditions, particularly macular diseases, glaucoma, and other optic neuropathies. The application of the OCT has principally relied on summary metrics, specifically the mean mRNFL, or retinal nerve fiber layer thickness, and the ganglion cell thickness, which I'm only going to touch on very briefly in this talk. What I will instead focus on is the qualitative use of the OCT in the evaluation of the patient with disc edema using the transverse axial, the en-face OCT, and the circular tomogram. I also hope to demonstrate its clinical utility and provide some tips on technical matters of acquisition and interpretation of these figures. The brevity of this introduction on metrics or quantitative OCT should not be interpreted to mean that this is unimportant. Quite the contrary. It's probably the most important aspect of the OCT analysis of the optic nerve. I just don't have enough time to cover everything in this one lecture, and it's a topic that's been extensively covered in the recent literature. I want to make a couple of points, though, about the metrics. The quantification of the optic nerve is based on the ability of the OCT to segment and measure the thickness of both the retinal nerve fiber layer, shown here in red, and the ganglion cell layer, which also includes the inner plexiform layer as well. This has enabled us to replace these subjective categorical grading systems that we used to use, the Friesen scale, with a continuous metric, specifically the mRNFL thickness and the ganglion cell layer, which in patients with papilledema shows thickening of the mRNFL, and in patients with optic atrophy will show thinning of both the mRNFL and the ganglion cell layer. Moreover, these commercial devices present the data in a very simplified stoplight graphical format that allows you to very quickly identify statistically abnormal values that are color-coded in red or yellow. And while these parameters can be extremely useful, there are several caveats that you need to consider when interpreting this data. One of the principal strengths of these parameters is the ability to compare and monitor progression over time. A decreasing mRNFL in a patient with disc edema is generally a sign of improvement. However, a decrease in the mRNFL can also be a sign of progressive axonal loss. And this is a distinction that can only be made by monitoring the visual field, which, if you can demonstrate a deterioration in the field while the mRNFL is decreasing, well, obviously that's a bad sign and needs to be addressed. The normal values that are used to analyze this metric data and compare your value to a control population are derived from a relatively small number of device-specific controls, anywhere from 200 to just a little less than 500 patients, depending on the device. The demographic profile, the inclusion-exclusion criteria can differ between devices as well. Most importantly, these normative values are based on adult populations, and so there are no normal values for children under the age of 18. We also know that myopes have a variety of anatomical anomalies, and thus these normative values are not adjusted for high myopia. Although there is a statistically significant difference between papilledema and normals and patients with drusen, there is some overlap between these groups of patients, and thus no single value, particularly in the region between 100 and 150 microns, will invariably exclude one or the other. Lastly, all of the commercial devices have difficulty segmenting severe grades of papilledema, that is, an RNFL of greater than 250 microns, grade 3 or above, because the segmentation algorithm breaks down. So you need to look carefully at the positioning of the segmentation line to see that it actually outlines the RNFL. Notwithstanding these limitations, the RNFL and the ganglion cell layer are powerful tools that can greatly supplement the exam and the visual fields and still represent the principal tool in evaluating a variety of optic neuropathies. What is less commonly appreciated is how the qualitative assessment can provide additional information. So let's start with the transverse axial. Why look at the transverse axial OCT? Well, it provides important information about the optic nerve head and the surrounding tissues, which can help in the assessment of shape, which we'll define as the configuration of the RPE layer shown here in red. It'll also help quite a bit in identifying patients with pseudo-papilledema. You can see evidence of fluid, edema, vitreous traction, inflammation, a variety of other features that may give you a clue about the underlying cause of the disc edema or the anomaly. If you're going to get a transverse axial, I would recommend 3 options or features that you include in your scan. One is that they're high resolution, they use the extended depth imaging, and that they're the widest possible angle. In the Cirrus, you will select the high definition raster, and in the options box, you'll be sure to change the length of the scan to 9 millimeters, and also be sure to check off the EDI. In the Spectralis device, there are boxes that allow you to choose these options, the EDI, the high resolution, and a 9 millimeter scan corresponds to these 30-degree scans. We wish to avoid as much as possible these tilted and distorted images, which occur because of an obliquely oriented scanning beam to the axis of the optic nerve. And you can eliminate this artifact by repositioning your scanning beam so that it's oriented temporal to the pupillary axis and perpendicularly aligned to the longitudinal axis of the optic nerve. The goal here is to line up the peripheral basement membrane, this point and this point, along a horizontal line. Many of the devices out on the market will, as a default, provide you with a vertically stretched image, which can be quite useful and help you interpret some of the images. However, you need to be aware of the degree of vertical magnification, because that might impact the appearance of the scan and possibly alter your interpretation. These are 2 examples of a patient with papilledema and normals. In the unstretched version, vertically stretched 1.4x, which is what you get out of the Spectralis, and vertically stretched 3x from the Cirrus. You can usually tell the amount of vertical magnification by looking at the size scale in the corner of the image. So before discussing the importance of shape, consider the principal forces acting on the nerve and the globe that may alter the shape. This includes the intraocular pressure, reciprocally related to the CSF pressure, as well as the retrolaminar tissue pressure and the orbital pressure. An imbalance in any one of these can alter the shape of the globe, and the response can be modulated by the compliance or the stiffness of the load-bearing structures, the sclera and the dura, as well as the lamina cribrosa. Now, the normal emmetropic eye has a curvature to it oriented away from the vitreous, which I'll describe as a V shape. If you increase the CSF pressure, or if you decrease the intraocular pressure, or if you stiffen the dura, all of these changes in the balance of those forces can cause an anterior shape deformation towards the vitreous. About 7 years ago, we looked at this in a quantitative way using a morphometric shape analysis technique. I don't have the time to go into it. Let me just summarize it very briefly by noting that if you look at a group of patients with papilledema, compare them to normals and ischemic optic neuropathy, the patients with papilledema had a shape that was anteriorly displaced towards the vitreous compared to the other two groups, and the difference was statistically significant to a very high degree. What this showed was that it was not the disc edema that caused this deformation, because the patients with ischemic optic neuropathy had just as much disc edema as the patient with papilledema, and yet they were no different than normals. Obviously, there was another factor involved, and the most likely culprit was the CSF pressure. We went on to show that if you decrease the CSF pressure, say by comparing the shape before and after a spinal tap, or before and after a CSF shunt, or before and after treatment of intracranial hypertension, what you'll find is that anterior deformed shape will move posteriorly to a more normal configuration. The problem with the geometric morphometrics is that it's very user unfriendly and not a practical way of assessing shape in the clinic. And until we can convince one of these OCT manufacturers to incorporate that in their software, we'll need a more practical way of doing this. And so after looking at thousands of these shape configurations, I would like to propose a more simple categorical system that can provide you with a vocabulary, at least, to characterize these shape deformations. This is an oversimplified description of the configuration, and it's all described relative to a horizontal line placed at the RPE basement membrane layer at each edge of the image, assuming that the basement membrane opening, the BMO, is centered in your slide and the image is flat, to describe the shape of the RPE basement membrane layer relative to this red line. I've identified 6 basic patterns. There is what I call a V shape, a slight curvature, as I showed you in the emmetropic eye, and then there are going to be a group of patients that have a flat configuration, and somewhere in between. Occasionally you'll see the lamina push forward without affecting the peripapillary tissue, which I'll describe as a W shape. Sometimes if the compressive force is asymmetric or off axis, you'll see an S shape. If there's a broad-based compression, we'll describe that as a dome shape or D shape, and occasionally you'll get this M-shaped configuration. So I wanted to see how these work out if you look at the group of patients that we're interested in evaluating. And we did this in a couple hundred patients, 325 eyes. If you look at the group of normal patients, you'll find that the overwhelming majority of these patients have a shape that varies between V and F. Very few showed this SWD configuration. In contrast, patients with papilledema showed that about 1/3 of them will have what you might think is a normal shape, that is, a V to F. But about 2/3 of them showed this SWD configuration. I'm often asked, well, if this patient has papilledema, why don't we see this anterior displacement? In 36% of the patients, well, yes, they can have a normal configuration, but remember, you don't know what they started with. They may have a flat shape, but they actually started with a V shape. They just haven't exceeded that threshold above the red line. Patients with meningiomas have a similar configuration or distribution of shapes, that is the SWD. I would not make too much of this difference on the normal side here because the numbers are too small to draw any conclusions. And patients with ischemic optic neuropathy, again, the great majority have this V to F continuum, a little bit more on the SWD side of the equation. Even if you don't know what the normal configuration should look like, it's sometimes useful to compare a baseline image with a follow-up image for shape changes. This can sometimes provide you with useful information. Now, in order to do that, you have to register the images, and there are multiple ways in which you can register. And again, I don't have time to go into all these different methods. Let me show you the method we've settled on. Basically, what I'll do is I'll take an OCT image, and we will identify or landmark the peripheral section of the RPE basement membrane layer, and then draw a line through the BMO, the basement membrane opening. Now we take our second image, which usually is not going to fit exactly the same way as the baseline image, and you'll have to do a little translation and rotation to align them to the landmarks and the BMO. Now you can sit there and compare the two shapes, and you can see that there is a difference in the configuration. You can measure the amount of displacement. You can take the average displacement at the center of the BMO. Now these little images here that you can do with Photoshop are very nice, but obviously not very practical. But you don't need to do that in the setting of the clinic or patient care. You can take the report that comes out of the machine, and you can trace out its configuration on a light box. You'll get the information that you need in that way. Let me show you an example about how these changes appear and how they can be used clinically. This series shows the rapid improvement over a period of 3 weeks in papilledema after a shunt. And you can see that very obviously in the fundus photo, and that's reflected in the mRNFL, which rapidly decreases over this 3-week period. But at the same time, you'll also notice that the configuration of the peripapillary RPE basement membrane layer and the margins of the basement membrane at the BMO gradually are displaced posteriorly, baseline being red and the white one being 3 weeks out. Now, obviously, you don't need an OCT to tell you that this patient's papilledema is getting better quite quickly. But there are some instances in which you don't have the luxury of monitoring the optic nerve head with papilledema. Many of these patients will have optic atrophy, and thus these optic nerves do not swell. And so in this particular patient, you can see the baseline configuration with an F shape. When the shunt failed, there was an anterior displacement, and when the shunt was revised, the peripapillary shape moved posteriorly into a V configuration. So in this case, it can be quite useful to monitor, that is, using shape as an indirect reflection of intracranial pressure. Let me show you another example of a 66-year-old diabetic with sudden vision loss, an afferent defect, mild diabetic retinopathy, and a swollen optic nerve head. Okay, clearly, this is a case of non-arteritic anterior ischemic optic neuropathy, or at least that was the diagnosis I made at the time, until I looked at the OCT, which in the normal eye had a V-shaped configuration, but in the affected eye showed this W shape. Now, I did say that W shapes can occur in ischemic optic neuropathy, but it's rare. Much more common in patients with papilledema and meningiomas. We got an MRI, and it showed that this patient had a meningioma. Let's talk a little bit about pseudo-papilledema. The difficulty in the diagnosis of optic nerve head drusen is that in the early stages, the drusen lie deep within the prelaminar optic nerve, and they are obscured by the overlying tissue. And with time, this drusen works its way up towards the surface and becomes visible. And that's true in about 2/3 of the patients. Now, there are multiple modalities that can help in identifying patients with buried drusen. You can see these drusen because they're calcified on the CAT scan, but that's not a very practical way of seeking drusen. Autofluorescence isn't bad, but these can also miss deep buried drusen. In the past, the ultrasound was the gold standard. The Optic Disc Drusen Consortium has identified the salient features of optic nerve head drusen on OCT. And it's all based on the fact that the OCT is properly performed, meaning that it is a high-resolution transverse or radial scan using EDI with closely spaced B scans. And the findings consist of a well-defined signal-poor area, occasionally capped with a hyperreflective margin, or sometimes containing multiple small aggregates of hyperreflective deposits, and occasionally you'll see these peculiar little horizontal lines. There is arguably an emerging consensus that the OCT, properly done, is the most sensitive and reliable way of detecting drusen. Let me give you an example. This is a patient with buried drusen, and you can see the drusen on the OCT, the ultrasound, and the autofluorescence. But in the other eye, which also has these drusen, you don't see them on the B scan, and you don't see them on autofluorescence. The early literature on OCT and drusen is a mess, related to a common feature that occurs, referred to as peripapillary, hyperreflective, ovoid mass-like structures. An unfortunate but descriptive name, which going forward I will refer to as FOMS, highlighted here in yellow. Based in part on first-generation low-resolution OCTs, these lesions were mistakenly thought to represent an uncalcified precursor of drusen. The consortium has made a compelling argument that these are not drusen. Let me show you why. Histopathologically, drusen, shown here, they leach out when you prepare the slide, are associated with these tissue masses, which have been shown with the proper stains to be basically axons or nerve fibers. Additionally, the identical structure can be seen in patients with papilledema, which again, Peyton has shown are due to distended axons in the peripapillary tissue. Moreover, you can see these FOMs in patients with meningiomas, ischemic optic neuropathy, papillitis. There's nothing specific about it. And also, when the disc edema resolves, these FOMs also disappear. These are not drusen. Another type of pseudo-papilledema, probably the most common cause of patients referred to me to rule out papilledema, is a mildly tilted disc characterized by this nasal elevation with a characteristic C-shaped pale halo that obscures the margin of the disc nasally and is most often seen in patients with a moderate degree of myopia, say about a -2 to a -6. Now, what makes these discs particularly confusing is the occasional occurrence of a spontaneously acquired, asymptomatic peripapillary subretinal hemorrhage, almost always located nasally or superiorly. I would distinguish this type of tilted disc from these severely dysmorphic and rotated discs that you can see in patients with tilted disc syndrome. The salient OCT features include nasal elevation. Sometimes you can see the margins of the scleral canal, and you'll see that it's obliquely oriented, frequently associated with a temporal crescent and RPE changes, or peripapillary atrophy. And the other feature is our friend, the FOM. So here's another cause of FOMs due to pseudo-papilledema, has nothing to do with drusen. Okay, let's talk about folds a little bit. Now that you've done your RNFL ganglion cell layer, you've looked at the transverse axial, you've looked for drusen, another feature to look for that's very useful are folds. In 1911, Peyton and Holmes wrote a seminal paper on papilledema, significant because it finally put to rest the idea that papilledema was an inflammatory optic neuropathy. In that paper, however, they made an observation about folds that has proven to be extremely useful, both clinically and pathologically, even today, and was widely acknowledged with an eponym referred to as Peyton's folds. And what they observed, as the disc swells, it displaces the retina into folds concentric with the disc, which is visible with the ophthalmoscope. And in a later paper, he had an illustration in which he described these grayish-white lines concentric with the disc that are obviously due to retinal folds. And this is what we mean when we say Peyton's folds. And he equated these folds with these folds. Now, although it seems a little bit ambiguous, he seems to suggest that the two are identical. However, if Peyton had an OCT and photographs, I'm sure he would have realized that these two are not the same. Let me show you why. Because in the study, we looked at the OCT and photos from all of the patients in the clinical trial, and we found that one of the more common types of folds was what I would refer to as peripapillary wrinkles, because they're so closely spaced and delicate, commonly referred to as Peyton's folds. And these folds are usually distributed in a concentric, sometimes spiraling pattern. They're almost always located on the temporal side of the disc, but the OCT shows that these folds are confined to the retinal nerve fiber layer. These en face OCTs were taken at the internal limiting membrane. They're best imaged using high-resolution en face and axial OCT. You'll notice that these folds, these Peyton's folds, are not in the outer retina. We did notice folds in the outer retina using the OCT. What Peyton described histopathologically is shown here in an OCT that looks remarkably similar. And yes, you can see them in the fundus, but they have a different appearance. They have a very subtle grayish lines, as he suggested. But what you'll notice is these are more widely spaced than the peripapillary wrinkles. Now, we had the opportunity to follow one of these patients because as the fluid resorbed, the patient developed these vertical lines shown here in the outer retina that correlated with these hypopigmented lines. And I had seen these little vertical lines and had a lot of difficulty trying to figure out exactly how those came about. And despite the fact that I had read Peyton's paper multiple times, I went back and I realized that Peyton already had the answer. He had one photomicrograph, which I had overlooked, which basically told us what this was. What you can see here is a deeply furrowed, self-contacting crease in the outer layer. That's what these lines represent. Since then, Roberta Seidman brought to my attention that in Ralph Eagle's pathology book, he's got a picture of a patient with disc edema with a triplet almost identical to my patient on the OCT. Now, we're actually very familiar with these creases because we've long known that when papilledema resolves, it leaves behind, on occasion, a ring of hypopigmentation, which we now know is actually one of these outer retinal creases, very nicely imaged on the en face OCT. We call them high watermarks. Now, we also observe several other types of folds. If you go to the literature on choroidal folds, you'll often see images that look something like this, and they're referred to as choroidal folds or chorioretinal folds. Well, with the OCT, at least in papilledema, these radiating folds or horizontal folds are not choroidal folds, because if you look at the OCT, you can see that these folds are confined to the inner retina, again, nicely imaged using en face, but that the choroid is spared. We call these inner retinal folds. And then lastly, there are the full thickness choroidal folds, usually oriented obliquely, horizontally across the posterior pole, full thickness and very widely spaced. What we found in the study was that among this 125 patient, 250 eyes, the relative frequency of these folds was pretty significant. The OCT was much better at detecting these folds than the photographs. And if you look at all comers, either eye, any type of folds, we'll see some type of fold in about 75% of the patients. So folds are common signs of optic disc edema, both past and present. And I'm talking about all four types of folds. And the importance and significance of folds is that they rule out pseudo-papilledema. Let me just show you how to en face. On the Cirrus device, you already have that information. If you got an optic nerve head cube to look at the mRNFL, instead of checking off the analysis button here, you're going to check off the en face option. And you're going to look and blow up this image, the VRI, vitreoretinal interface. In the Spectralis, you're going to get a volume scan and go to the 3D tab, click Transverse, ILM, or vitreoretinal, and you'll look at the image in the upper right. The interval has to be less than or equal to 60 microns. In order to see folds, you must, especially in the Cirrus, optimize the offset and slab thickness. This is the same patient. If you don't adjust these lines so that they straddle the surface of the vitreoretinal interface, you will miss the folds. If the folds are oriented in a particular direction, so let's say horizontal folds, and you take a transverse scan, you will miss the folds. In order to see the folds, you have to cut across them perpendicularly, and then the folds become evident. This is the same patient. This requires another special scan, but actually you don't have to do that, because if you looked at the mRNFL, you obtained a circular scan, which will give you a flattened out tomogram of the 360 degrees, and at some point one of these sections of the circumference will cut across these folds perpendicularly and display them for you so that you can see them. Let me give you an example of how I use this. This is a 31-year-old patient, borderline obese, asked to rule out papilledema, a normal exam, no B-scan drusen or drusen by OCT. The MRI was normal. This is the appearance of the disc. The fields were normal. The OCT was normal. I looked at the shape configuration. I got a V on the right, a flat or a F on the left. But look at the en face OCT. You can clearly see that this patient has folds. The opening pressure in this patient was elevated at 33 centimeters. Another example, a patient with very suspicious looking optic nerves, and you immediately see that by autofluorescence ultrasound and by OCT, the patient has drusen. Problem is, the patient also has folds. Here's the rule. Folds in optic nerve head drusen indicates a concurrent problem. And in drusen, the two most likely possibilities are that the drusen is complicated by an ischemic optic neuropathy, or they may have the coincidental occurrence of papilledema. In this patient, we also noted the presence of an S-shaped configuration and a D-shape. Starting to think papilledema here. In fact, the patient had an aqueductal stenosis with hydrocephalus. So you can have both pseudo-papilledema and papilledema. Okay, let's talk about the effects of eye position or adductions on the optic nerve. If you acquire a transverse axial in primary position and then repeat that exact same OCT with the eye 30 degrees abducted and then 30 degrees adducted, and then superimpose those images and loop them, you will observe a very stereotyped pattern of deformation illustrated here in this normal subject. Specifically, a relative rocking motion or seesaw deformation at the BMO such that the temporal margin is posteriorly displaced away from the vitreous in adduction, it's anteriorly displaced on the nasal side, and the reverse occurs in abduction. And what you'll also notice is that notwithstanding the presence of disc edema in ischemic optic neuropathy or optic nerve head drusen, the deformation is the same with respect to the pattern and the magnitude of that seesaw or tilting motion. Now, the angle formed by the two lines joining the margins of the basement membrane layer is in the order of about 2 to 4 degrees or so. The effect in papilledema, however, is quite different. Although the pattern is preserved, that is posterior displacement in adduction on the temporal side, the magnitude of the seesaw is greatly exaggerated. It extends well beyond the BMO into the peripapillary tissues and also involves the lamina cribrosa. You'll also notice something peculiar here is that if you look very closely, when this yellow arrow appears, which appears in adduction, you'll notice that there are these fine little folds that develop on the temporal side of the disc. That is, folds are present only in adduction, not present in abduction. Let me show you some other examples. This is a patient with a grade 2 papilledema, and while the patient does have some barely detectable folds in the supratemporal area, seen in primary position in abduction, in adduction these folds become greatly exaggerated and much more visible. You can see that very nicely on the en face slab shown here, and again here on the transverse axial. This is a 3D reconstruction. Let me give you an example of how you can exploit this feature. This is an 18-year-old woman, BMI of 31, headaches, normal vision, pupils and fields. This is the appearance of the disc. The mRNFL is normal. I looked very carefully for folds, did not or could not convince myself the patient had folds. The shape pattern looked pretty normal to me. I'd call that a V shape. But if you look at the en face OCT and compare it in adduction to primary and abduction, you can see that there are folds that are only present in adduction, in both eyes. Moreover, the seesaw tilt angle was about 12 degrees in one eye, 10 degrees, a bit more than the 2 or 3 degrees you see in normal subjects. Opening pressure was 32, by the way. Treat the patients 2 months later. Here's the baseline OCT, the folds in adduction shown here. 12 degrees. After 2 months, the folds disappear and the tilt angle decreases. So it appeared to me, at least based on this patient, that this has something to do with the tilt angle. And so what we decided to do is to look at this more systematically, again, taking these 3 images in primary abduction, adduction, in a group of patients, normals, drusen, and 32 patients with papilledema. Because it was possible that these folds appear in adduction on everybody. So let me put that to rest. Normals and patients with drusen don't develop folds in adduction across the board. They don't have folds in primary either. Now, the patients with papilledema fell into 4 categories. About a third of them showed no folds at all. Another 13% showed folds that did not change in eccentric eye position, and about 2/3 of them showed folds that got worse in adduction, and 20% of which had folds that were only present in adduction. How does this relate to the seesaw tilt angle? Well, first of all, by comparison, this is the tilt angle from all 4 groups compared to normals. You can see they're quite different. And within the subcategories, those patients whose folds got worse in adduction or only in adduction were significantly greater than the other 2 groups, the A and B, and certainly much greater than the normals. So adduction-evoked peripapillary wrinkles are associated with large seesaw deformations. Why does this happen? Well, folds come about whenever you apply a force or stress to a surface layer on a compliant substrate. And the pattern of folds is a function of its structural geometry and the way in which you apply the force, the loading force conditions. If you compress a surface layer, folds will form perpendicular to your compression. If you pull it and apply a tensile force, the folds will align themselves with the direction of the tensile force. In the study that we published, we found that these peripapillary wrinkles correlated with the degree of volume expansion, which in experimental models causes compressive forces on the surface. And when the base is constrained, you develop a hoop stress, which is basically a tensile force at its base. That's what gives rise to peripapillary wrinkles. Well, these observations that I just showed you suggest that adduction also stresses the optic nerve. And what happens in adduction is you end up stretching the optic nerve sheath in adduction, and this tethers the globe temporally and posteriorly. And that's what we saw in the normals of ischemic optic neuropathy intrusion. But in papilledema, in addition to the tethering you get from adduction, you also have additional forces caused by shifting CSF fluid, pressure on the flange, and hydraulic stiffening. Now, I've talked mostly about the z-axis deformations anteriorly and posteriorly, but keep in mind, this is a three-dimensional effect. You get translational effects on the surface in the XY plane, temporally in adduction. And remember those spiral folds I showed you? That strongly suggests that there are rotational forces as well. So, in summary, peripapillary wrinkles distinguish papilledema from pseudo-papilledema. Adduction stress testing, in other words, looking for folds in adduction, will enhance and expose peripapillary wrinkles. Sometimes, even if you don't see them in primary position, they will induce these large seesaw deformations. And this little test is most helpful in identifying low-grade cases of papilledema. Early papilledema, resolving papilledema, even resolved papilledema from our prior bout, because these folds can persist for many years. Let me just close out by just showing you a couple of miscellaneous findings. Ischemic optic neuropathy frequently associated with peripapillary fluid, sometimes extending into the macula. Inflammatory optic neuritis or papillitis. You can see the cells in the vitreous, frequently associated with lots of fluid. These cells can aggregate on the surface and form these epipapillary infiltrates. I suspect that that's what people used to talk about granulomas of the optic nerve. And you can see the usual panoply of outer retinal folds. You can see inner retinal folds, peripapillary wrinkles, the whole nine yards, and of course macular edema. So let me summarize this whole thing. What I've tried to give you here today is a toolbox for you to evaluate optic neuropathies, in particular disc edema. I don't think we're at the point yet that the OCT has supplanted the exam, although I don't know what's going to happen. Ask the neurologist what happened with the MRI. But I still think we have to do an exam, visual field ophthalmoscopy, and I still believe that the RNFL and the ganglion cell layer are the go-to modalities of the OCT that can be extremely helpful in optic neuropathies. However, in those cases in which you're trying to distinguish papilledema or disc edema from other optic neuropathies, consider the shape deformation, especially the WSD configuration. Look for the drusen or the oblique insertion and features of myopic tilted discs. A careful look. You have this information anyway. Take a look at that en-face OCT for folds. If you don't see the folds, look at them in adduction. You may be surprised. If you really want to dive deep into the weeds here, you might even want to check the tilt angle and, of course, these other miscellaneous features.